Good day everyone and welcome to our virtual orientation seminar on patient safety courses, particularly on infection prevention and control practices and healthcare waste management. I am Dr. Giovanni Hitulio T. Zinarosa, your overall chairperson of the Hospital Patient Safety Committee. First and foremost, let me express my gratitude to all of you for joining us today. It is our shared goal to enhance patient safety and the well-being, and I believe this orientation will be a great start in achieving this objective. Your commitment to learning more about patient safety shows your dedication to providing excellent healthcare services. In the healthcare industry, patient safety is of utmost importance. It is crucial that we take all necessary measures to prevent the spread of infection and maintain the clean and safe environment for our patient, staff, and visitors. This is why infection prevention and control practices are crucial, and we must ensure that they are adhered to by everyone. Another essential aspect of patient safety is proper healthcare waste management. Proper waste management reduces the risk of infection transmission, occupational hazards, and environmental pollution. We must always follow the latest updates and best practices in this field to ensure we are doing everything we can to maintain a safe and healthy environment for everyone. Again, throughout this seminar, we will be discussing two critical areas of patient safety: the infection prevention and control practices, which will be discussed by Mr. Mark Joseph Olayon, Nurse 4, and healthcare waste management by Engineer Reuben Espartines, our pollution control officer. By the end of this orientation seminar, I hope you'll walk away with heightened awareness of patient safety issues, a solid understanding of best practices, and the motivation to integrate patient safety principles into your daily practice. Thank you for joining us today, and I'm excited to embark on this learning journey with all of you. Let's work together to create a safer healthcare environment.
Good day to each and everyone. I'm Mr. Mark Joseph D. Olayon from Infection Prevention and Control Unit, and I am here to discuss the basic hospital practices in preventing and controlling hospital-acquired infection and other transmissible diseases. At the end of the discussion, the participants will be able to first describe Infection Prevention and Control Unit in terms of background, structures, and programs, identify and explain the basic infection prevention and control practices with emphasis on two tiers of precaution, namely the standard and the transmission-based. And third is to enumerate the step-by-step process of consultation, screening, quarantine, and resumption to duty if exposed to highly communicable disease or highly communicable patient, or if with signs and symptoms of communicable illnesses. In this presentation, we will discuss the three subtopics as reflected on the outline. Allow me now to discuss the first subtopic, which is the background, structures, and programs of infection prevention and control. Infection Control Committee in healthcare facility all started when the Department of Health issued a memorandum and administrative order requiring all healthcare facilities, particularly the DOH retained hospitals, to establish Infection Control Committee. On September 26, 1996, the revised rules and regulation governing registration and licensing of hospitals again reiterated that each hospital should establish three vital committees, and one of which is the Infection Control Committee. But the pivotal role of Infection Control Committee was then observed during the SARS outbreak, when there was no known treatment available, and the only way to prevent and combat the spread of infection is through adherence to infection control policies and guidelines. So through the initiative of the World Health Organization and the Department of Health, in collaboration with three specialty organizations, the Philippine Society of Microbiology and Infectious Diseases, the Philippine Hospital Infection Control Society, and the Philippine Hospital Infection Control Nurses Association. So they conducted a series of assessment studies in all healthcare facilities across the nation. And one of the criteria of their assessment was to determine the effectiveness of the implementation of the infection prevention and control programs. And based from their findings, it revealed major deficiencies in terms of the knowledge, practice, and policy compliance among healthcare providers. That's why the DOH and the WHO even provided a recommendation to strengthen the infection control programs, particularly when responding to infectious disease outbreaks and pandemics. And more than a decade after the said observation, same observation was still noted when the COVID-19 emerged. In every healthcare facility during the start of COVID-19 pandemic, they observed that there was a major gap between the knowledge and the compliance of the staff or healthcare providers to infection prevention and control. So to address this gap, our institution strengthened its infection prevention and control programs through its own infection prevention and control unit. So the BMC Infection Prevention and Control Unit is being headed by no other than Dr. Jose Manuel Tiranola, who is also the head of the Emerging and Re-emerging Infectious Disease Center. He is being assisted by his vice chairman in Infection Prevention and Control Committee, and also the assistant head of the Emerging and Re-emerging Infectious Disease Center, Dr. Cherry Pinky Malati Budao. So all of the reports, whether it is an accomplishment or a finding, are being reported or submitted directly by the Infection Control Unit to the Medical Center Chief, Dr. Ronnie Gregorio Biggie Gantoni III, since the Medical Center Chief has the direct authority over the Infection Prevention and Control Unit. So together with Dr. Ranyola and Dr. Budao, the Infection Prevention and Control Unit has its unit nurse supervisor, Mr. Henry V. Prestado, who oversees the daily operations of the Infection Prevention and Control Unit. To assist Sir Henry Prestado, there are 3 infection prevention and control nurses assigned in the unit. Yours truly, Nurse 4, Miss Ma'am Melanie Camasis, Nurse 2, and Sir Edmil Villa, Nurse 2. But since we are a 1,000-bed hospital, in order to ensure that there is an effective implementation of infection prevention and control practices in each clinical area, that the Infection Prevention and Control Unit assigned different IPC links at the different areas of this institution or clinical areas, as reflected on your screen. So IPC links are nurses. They are nurses who were trained for Infection Prevention and Control Unit, and their main role is to coordinate consistently with Infection Prevention and Control Unit, particularly in planning, implementing, and evaluating the infection prevention and control programs. So whatever best practices they have, or whatever gaps they noted in their area, they should consistently coordinate that to Infection and Prevention and Control Unit to further improve, or at least to address the said gaps or problems or IPC related problems systematically. So the Infection Prevention and Control Unit as an organization aims to further improve from its current situation, and it aims to have a better impact with the healthcare institution. So in order to attain such aim, the Infection Prevention and Control Unit is being guided by its vision, and that is to create a clean and safe medical center that is proactive and responsive in the prevention and control of hospital-associated infections, as well as of the transmissible diseases. And to support the vision, the IPC unit's mission is to provide a comprehensive infection prevention and control services, training and research, adding value to patient care and personal safety. So anchored to our vision and mission are our core values: commitment, innovation, teamwork, and excellence. But in order to translate our mission into specific actions, we need to fulfill our objectives. The first objective is to develop policies and initiatives for the prevention and control of healthcare-associated infections. Number two, prevent the spread of infections or prevent the spread of infectious diseases and BMC through evidence-based infection prevention and control measures. Third, provide technical expertise for infection control preparedness and response to health emergencies and other potential concern. Aside from which is to provide training to every employee as well as every trainee in basic infection prevention and control, as well as updates on the management of infectious diseases. Of course, to promote and conduct research in terms of hospital infection prevention and control practices. And lastly is to establish linkages with other facilities with the aim of improving the infection prevention and control programs in all healthcare facilities, particularly within the province of Camarines Sur. And the aforementioned objectives are the one we consider, particularly in implementing the programs mandated by the Department of Health. And the objectives that I mentioned are the ones we consider in implementing our programs. And what are the programs under Infection Prevention and Control Unit? These are, first, the monitoring and surveillance of healthcare-associated infections. Second is the monitoring and management of needle, stick, and sharp injury and other forms of unprotected exposures to blood and body fluids. Third is the immunization program for healthcare workers. Of course, orientation program like this, and hand hygiene program, hospital environmental cleaning and disinfection, reprocessing of reusable equipment and devices, water samples, bacteriological examination, environmental sampling and instrument swabbing, antimicrobial stewardship program, and other related functions assigned by the medical center chief. But despite of having these different infection prevention and control programs, we will not be able to create a clean and safe medical center if we will not do our job, our part as healthcare workers in observing infection prevention and control practices. Thus, I will move to my second subtopic, which is infection prevention and control, 2 tiers of precaution. The 2 tiers of precaution is an approach introduced by the Center for Disease Control and Prevention with the goal of establishing measures on how we are going to protect our healthcare workers from getting infected within the healthcare setting. So the 2 tiers of precaution pertains to the 2 levels of precautions that each healthcare worker should observe when performing any clinical activity. So the first level of precaution or protection is the standard precaution. And when standard precaution is not enough, on top of observing standard precaution is another set of precaution, and that is the transmission-based precaution applicable when managing only infectious or highly infectious patients. But in order to understand the 2 tiers of precaution, let us discuss first the standard precaution. The standard precaution is now the term being used as replacement of the universal precaution, because universal precaution is no longer used as a term in the medical community. So, standard precaution pertains to basic measures to reduce risk of transmission of infectious agents from both recognized and unrecognized sources, be it blood or body fluids, secretions or excretions, non-intact skin and mucous membrane, and any equipment or contaminated equipment in the care environment. So the standard precaution can be used by all staff in all healthcare settings at all times for all patients. Meaning to say, standard precautions are set of practices that we need to apply when taking care of the patient, regardless if the patient is communicable or not. And what are those activities under standard precaution? These are hand hygiene, use of personal protective equipment or PPE according to risk, respiratory hygiene or also called as the cough etiquette, safe injection practices, sterilization or disinfection of medical devices, and lastly is the environmental cleaning. First, let us focus on hand hygiene program. Hand hygiene is considered to be the cheapest, yet the single most effective way of preventing and managing cross-contamination. But why is it important that every healthcare worker should comply to hand hygiene protocols? It's because globally, out of 100 patients, 15 patients acquired healthcare associated infections in developing countries, and the cause of which was the poor compliance of healthcare workers in the healthcare setting. In our institution, last year, 186 healthcare associated infections were recorded, and one of the major factors that contributed in the occurrence of the healthcare associated infections in our healthcare institution was because of the poor and non-adherence of our staff to hand hygiene practices. And in order for each healthcare worker to have a greater compliance to hand hygiene practices, the World Organization introduced the 5 moments of hand hygiene. So this approach by the World Organization will serve as a reminder for each healthcare worker that we need to practice hand hygiene during these 5 critical events. And what are these 5 critical events? Before touching the patient, before clean or aseptic procedure, after body fluid exposure risk, after touching the patient, and after touching the patient's surroundings. If we're going to translate it in the office tasks or tasks within the different offices, so it is important for us to perform hand hygiene once we touch a particular material in our office that might probably contaminated with microorganism, and after touching the surroundings within our offices. But within the clinical care setting, and this is also applicable in the offices, observing hand hygiene is not only confined on using soap and water, because at present, there are 2 hand hygiene practices that are being observed in order to prevent the possible cross-contamination within the healthcare setting, particularly in the acute care hospitals. The first practice is the hand washing, while the other one is the hand rub. Although these 2 hand hygiene practices have the common goal of preventing cross-contamination by ensuring that there will be no presence of microorganism or infectious microorganism on our hands. But these 2 practices have also differences, particularly in terms of the material being used, duration, and the best time to perform. It is said that if our hands have visible dirt, we need to perform hand washing. And for performing hand washing means you need to use soap and water, preferably antibacterial soap, and at the same time that we need to do or perform hand washing between 40 to 60 seconds or 1 happy birthday. But on the other hand, if our hands have no visible dirt, but we perceive that our hands are contaminated because we touched the patients or because we touched an item that is possibly contaminated, then we need to perform or observe hand hygiene practice through hand rub. Hand rub means cleaning our hands using 70% ethyl alcohol or alcohol-based gel, and we need to perform that between 20 to 30 seconds. And how are we going to perform these two hand hygiene practices? There are steps being recommended by the World Health Organization in performing hand washing or hand rub. So let us discuss first the steps of hand washing. For the hand washing, we need water in order to wet our hands, then apply enough soap. Once we apply enough soap, then we need to rub our hands palm to palm. Then we need to rub the right dorsum with the left palm over it and vice versa. Then we need to rub palm against another palm or the opposite palm with fingers interlaced. Of course, back of fingers to the opposing palm with fingers interlocked and vice versa. Then, rotational rub right thumb clasped in left palm and vice versa. And then, rub the right palm using the fingers of the left hand and vice versa. And then we need to rinse our hands with running water or water. So we need to use a single towel or a paper towel to dry our hands, and we need to use that towel in turning off our faucet to prevent contamination. Then, our hands are now clean and we are now ready to perform any clinical activity, particularly if we're going to perform any clean or aseptic procedure. On the other hand, the steps of hand rub are similar to hand washing. We need to apply a palmful of the product in our cupped hand, and we need to cover it or to cover all the surfaces of our hands. So let us start with rubbing our hands palm to palm, left palm over the right dorsum and vice versa. So palm to palm with fingers interlaced, back of fingers to opposing palm with fingers interlocked, and of course rotational rub of the right thumb clasped in left palm and vice versa. Rotationally rub right palm with fingers of the left hand and vice versa. And once dry, our hands are now safe and ready to perform clinical activity. Remember, hand hygiene is considered as the cheapest way of preventing and controlling infection. But even if there are several advancements in terms of infection prevention and control, still, hand hygiene remains as the single most effective way of preventing and managing infection, being applied both in the industrialized and developing countries. Another activity under the standard precaution that provides additional protection to healthcare workers aside from hand hygiene is the use of personal protective equipment. Personal protective equipment are the reusable or single-use coverings that are being used by our healthcare workers, particularly when providing care or providing direct care to a patient, much so if the patient has communicable or infectious illnesses. In our institution, we categorized the use of personal protective equipment into 4. We based our categories on the hospital zoning that has been implemented in this institution since the start of COVID-19 pandemic. So in Bicol Medical Center, there are 3 zones, namely the green zone or the clean area. For example, or the areas under the green zone are all offices. For the yellow zone or the potentially infected area, these are the areas that have direct interaction with the patient, but the patients are non-COVID or the patients have diseases that are not communicable. And the third one, the red zone or the infected area. These are the areas that manage COVID-19, particularly the isolation rooms per clinical unit, as well as the emerging and re-emerging infectious disease center. So also, part of the red zone are those areas or rooms that handle not only COVID-19 patients but also other emerging and re-emerging infectious diseases. So with these hospital zoning that we arrived with these four categories of PPE, and here are the four categories of personal protective equipment being implemented in this institution. So first category is the use of disposable face masks. So the category 1 PPE or the use of disposable face mask is only applicable to areas that have low risk of exposure to communicable diseases. So these areas are under the green zone: offices, pharmacy section, HIMSS, Malasakit Center, billing section, cashier, PhilHealth processing section, main entrance and exit points. And the common activities under these sections are office tasks involving interaction with colleagues and or patient significant other, but no interaction with the admitted patients. So category 1 PPE is also being used in the yellow zone or potentially contaminated area, specifically at the OPD clinics, except for OR of ambulatory surgical clinic, nurse station, and hallways of non-irid wards, with the common clinical task of having direct interaction with the patient's significant others. Also, category 1 PPE is being used in the receiving or lobby areas at the main laboratory, bacteriology or microbiology section, and radiology section. In the red zone, we can only use the category 1 PPE if we are at the main lobby area of the main lobby area and the nurse station of the red zone, or particularly nurse station of the irid center, as the clinical tasks involved in this area are only interaction with the other healthcare workers. But we need to use category 2 PPE, which means we are not using only our face mask on top of the, or in addition to the face mask, we need to use head or hair cap as well as gloves and face shield if applicable to areas that have a moderate risk of exposure or have possible moderate risk exposure to infectious illnesses. And what are these areas? So under the yellow zone, we have the new ER and OBER, as well as the OPD triage areas, where the common clinical activity is to screen or triage ER and OPD patients. Of course, under yellow zone, we need to use category PPE in the diagnostic rooms of radiology department when facilitating radiologic procedures for non-infectious patients. We need also to use category 2 PPE at the ER cubicles and labor rooms of the ER complex, with the common clinical activity of conducting rounds and health assessment, administering medications or changing IV fluids, blood extraction, and other clinical activities that will not cause blood splashes or splashes of blood or body fluid and will not generate aerosols for patients with non-infectious diseases. Category 2 PPE can be used also at non-irid, non-ICU rooms, with the common clinical activities of conducting rounds and health assessment, administering other medical and nursing procedures without the possibility of causing blood or body splashes, blood or body fluid splashes, and generating aerosols. So category 2 PPE can be used also at the main laboratory blood extraction area when performing blood extraction to OPD or walk-in clients, at the laundry section or housekeeping section when collecting used linens, cleaning of non-isolation rooms, nurse stations, and offices, as well as when processing reused linens. And lastly, category 2 PPE can be used also at the lobby, hallways, and nurse station of OR, DR, and ICUs. So when performing clinical tasks at receiving areas, hallways, and nurse stations of OR complex, DR complex, and ICUs. However, for intensive care unit and delivery room, if a healthcare worker who is not from the said area, not wearing scrub suit, has no dedicated ICUs and visited only the unit to perform brief clinical activities, a reusable gown and shoe cover must be worn aside from hair cap and mask before entering the ICU station. From the category 2, we go now to category 3 PPE. The category 3 PPE is composed of head or hair cap, shoe cover, sterile or non-sterile apron or medical gown, face mask or respirator, goggles or face shield, and single layer of non-sterile or sterile gloves. It can be applied to those areas with moderate to high risk level of exposure to communicable or infectious patients. It can be applied to those areas such as under the yellow zone, we have the ER cubicles, non-arid ICUs and non-ICU rooms, delivery room, and dental clinic, particularly when performing clinical activities to non-infectious patients that may involve splashes of blood and body fluids, generate aerosols, or direct contact to respiratory secretions. It can be applied also at main laboratory, bacteriology or microbiology, histopath sections, and diagnostic rooms of radiology department when processing specimen or facilitating radiologic procedures. Category 3 PPE can be used also at OR theaters when performing surgical operations to patients diagnosed with non-infectious diseases, provided that the gown and the gloves are considered sterile. And at the red zone or highly contaminated areas, it can be used at non-arid isolation room except the ER isolation when performing medical and nursing procedures. And lastly, the last category, which is the category 4. So it is composed of head or hair cap, shoe cover, sterile or non-sterile medical gown or protective cover, all with or without PAPR, respirator, goggles or face shield, and double layers of non-sterile or sterile gloves. So it can be applied at areas with high level of exposure to infectious illnesses or communicable diseases, particularly at yellow zones, the diagnostic rooms of radiology department when facilitating radiologic procedures to highly infectious patients, at the red zone, specifically at the ER isolation room, non-arid isolation rooms, hot and warm zones of arid facility, bacteriology section or microbiology section, and molecular laboratory and morgue, when caring for patients under airborne precaution, droplet and contact precaution, as well as when cleaning the isolation rooms and highly contaminated surfaces. And of course, at non-arid OR isolation rooms and arid OR, or OR designated for the surgical operations of highly communicable patients, be it arid or a non-emerging and re-emerging infectious diseases. So, when performing surgical operations to patients diagnosed with highly communicable diseases. But even if we use a proper PPE, but we do not know how to don or doff the set of PPE, then there is a higher chance again that cross-contamination might happen. That is why the Infection Prevention and Control Unit recommends that when a healthcare worker uses a set of PPE or a set of full PPE composed of shoe cover, gown, hair cap, a mask, goggles, and gloves. So it is a must that the set of PPE shall be worn inside the donning area or designated donning area. And the first thing that we need to do is to wear our shoe cover, perform hand hygiene, then don our medical gown. After the gown will be our hair cap. After donning the hair cap or after wearing the hair cap, we need to use our face mask, don our goggles, and lastly is to don our gloves. And then the gloves should overlap should overlap on the lower cuff of the gown. And after the clinical activity, when using full PPE, we need to proceed to the designated doffing area to remove our PPE in a proper order. Because again, even if we're using a full set of PPE, but if you don't know how to remove that in a proper manner, there is a higher chance that contamination might take place. That is why, inside the designated doffing area, before you proceed to the nurse station or to the clean zone, you need to remove the PPE, and the proper sequence of PPE starts with conduct of proper hand hygiene, removal of the gloves. After removing the gloves will be the removal of the gown. After removing the gown, we need to doff our goggles. Make sure that when we doff our goggles, we need to touch not the front surface of the goggles, but only the arms at the side. And then remove our shoe cover. Then from which removed the face mask, and the last PPE that we need to remove is our hair cap. But mind you, in between the removal of each PPE, we need to perform hand hygiene. Because in the event that we accidentally touched the contaminated surface of the PPE, at least performing hand hygiene in between the removal of PPE might prevent the possible contamination. Aside from that, another questions commonly asked to infection prevention and control unit is that what is the recommended length when using a certain type of PPE? So we need to focus only on the hair cap, shoe cover, disposable gown, medical face mask, respirator, goggles, and gloves. It is said that when we are using hair cap, shoe cover, disposable gown, and disposable gown, the moment that we remove the hair cap and the shoe cover as well as the disposable gown, we cannot reuse it, or we cannot wear it again for another patient. For the medical face mask, respirator, and goggles, we can use that in the extended period for up to 6 hours. But the moment na the medical face mask, the respirator, the goggles, or the face shield got soaked, we need to replace that with another or with a new set of medical face mask, respirator, and goggles. And for the gloves, there is no quality evidence available on the extended use of gloves for multiple patients, and it is not solely advised. How about reprocessing? Another question that we commonly received from the healthcare workers is the proper way of reprocessing in storing reusable personal protective equipment. So, on the information that we collected and based on our manual, disposable hair cap, shoe cover, medical mask, medical gown, protective coverall, and gloves that are classified as a single-use type of PPE are not advisable to be reused. But if the PPE, the hair cap, the shoe cover, medical gown, and protective coverall are made up of cloth, then we need to reprocess these types of PPE through proper reprocessing being observed in the linen and laundry section. For the goggles or the face shield, the proper reprocessing method is to clean and disinfect the surface where the eye protection item will be cleaned, performing hand hygiene and donning gloves, cleaning with soap, detergent, and water on clean cloth, and allowing time for eye protection item to dry. Wipe with a clean cloth or wipe using 70% alcohol or sodium hypochlorite, and assess the goggles and face shield after cleaning if the functional shape is maintained, the arms or straps are damaged, or the clarity of the screen or lens has decreased. Then, we need to store that and to arrange that properly in a designated cabinet. For the N95 or the N100, after doffing the respirator, and if we use the respirator only in managing a patient without performing any aerosol generating procedures, then we can reprocess the respirator. So, in reprocessing the respirator, the wearer shall check the mask for any deformity in structure and signs of severe contamination. If with severe deformity or contamination, discard the respirator. Respirator should not be reprocessed when it was used in performing aerosol generating procedures such as intubation and suctioning. Using clean tissue paper, clean with soft strokes the inner side of the respirator, avoiding to cause structural damage and without touching the outer side of the respirator. Then discard the tissue paper. Clean the straps with disinfectant wipes followed by dry tissue paper without touching the outer surface of the mask. And then while holding the strap and using a clean and dry tissue paper, clean the outside or outer side rather of the respirator without touching on it and causing structural deformity. Place it inside the clean brown envelope or paper bag with puncture holes. So the conservative recommendation of the United States Center for Disease Control and Prevention, National Institute for Occupational Safety and Health, is that a respirator should be donned a maximum of 5 times only. However, if the respirator is not snugly fitted with leakage noted during the seal check, or if with foul odor, even if it was used only twice or thrice, it should be not reprocessed. And of course, if the N95 or N100 mask was used in performing aerosol generating procedure such as intubation, such as suctioning, such as nebulization, then the N95 or the N100 mask shall not be used or shall not be reprocessed. The third standard precaution is the respiratory etiquette or the cough etiquette. Respiratory etiquette is a standard precaution and source control measure in the healthcare setting with the purpose of containing the respiratory secretions to prevent or limit the transmission of microorganisms which can spread through airborne and droplets or through airborne and droplet routes such as coughing, sneezing, talking, singing, and others. So, and what are the guidelines of our hospitals in observing respiratory hygiene practices? Number 1. When coughing or sneezing, use a tissue or personal towel or handkerchief in covering the mouth or nose. Then, dispose the contaminated tissue in a yellow trash bin with cover. If the one being used is a personal towel or handkerchief, refold it so that the surface that came in contact with the mouth or nose is at the inner folded part. Then place immediately the personal towel or handkerchief inside the pocket or bag intended for the contaminated clothes. In the absence of tissue or personal towel or handkerchief, a person shall cough or sneeze into his elbow or sleeve to prevent projecting the droplets or droplet nuclei to other person in front or to the environment. Wash the hands with soap and water after coughing or sneezing or by using 70% ethyl alcohol. Or if came in contact with surfaces contaminated respiratory secretions. If sink is not accessible, again, use alcohol-based solutions and perform hand rub. Alcohol hand rubs shall be available in strategic places such as main entrance and exit points, lobby areas, hallways, nurse stations, and patient rooms. Healthcare workers shall also bring packet-sized alcohol hand rub, while patients and significant others also are advised to bring alcohol and tissue paper. Patients with respiratory symptoms shall wear face masks. If health condition cannot tolerate wearing face masks, the patient shall be assessed and shall be isolated as per doctor's order. Also, our we as healthcare employees rather, have the duty to wear our face mask inside the hospital premises. Wearing face masks can protect the healthcare workers from getting infected with respiratory pathogens. More so, to prevent contamination, even when using face masks, we need to avoid the common mistakes when wearing face masks. Number one, do not wear your face mask under your nose or mouth. Do not allow a strap to hang down and do not cross the straps. Do not touch or adjust your face mask without cleaning your hands before and after. Do not wear your face mask on your head. Do not wear your face mask around your neck, and do not wear your face mask around your arm. Another activity under standard precaution that every healthcare worker should observe is the prevention and management of exposure to blood, body fluids, and other risks. Based on our data from Infection Prevention and Control Unit, last year alone, there were 57 employees who were accidentally pricked with contaminated needles or sharps. This is considered a major occupational risk, as needle stick or sharp injury or injury obtained from a contaminated needles or sharps can cause a possible transmission of bloodborne pathogens, particularly the hepatitis B, hepatitis C, and the human immunodeficiency virus. In order to prevent the needle stick and sharp injuries, as well as other forms of unprotected exposures to blood and body fluids, there are several strategies being recommended by the Infection Prevention and Control Unit. Number one, eliminate the hazard. If possible, we need to shift our intravenous medications, if possible, to other routes of administration to minimize the exposures to needles. However, if eliminating the hazard is not possible, then we need to observe other preventive measures or strategies such as engineering innovations, use of needle devices with safety features, and of course, we need to observe safe work practices. Number one practice that we need to observe is the avoidance of recapping of needles. Do not bend, recap, or remove contaminated needles and sharps. Because any type of recapping, be it this one or be it a scooping technique, is not allowed in this institution. What we need to do is to pick up a forceps, place it around the needle hub, separate the needle from the plunger or from the syringe, dispose the needle immediately to puncture-resistant container, and dispose the sharp to designated yellow trash bin for contaminated syringes. Then, make sharp containers available and accessible to the point of use. Sharp containers should puncture resistant, leak proof sides and bottom, and with a secure lid for closure. Check sharp containers regularly and discard or replace them before they are full. Sharp containers should be closed, discarded, and replaced, or must be replaced when the sharp containers are approximately 3/4 full. Another is the use of personal protective equipment. Rational and proper use of personal protective equipment when performing procedures may help us in preventing needle stick and sharp injury, as well as other forms of unprotected exposures to blood and bladder fluids. Also, We need to implement administrative controls such as continuous updating and proper implementation of policies on needle stick and sharp injuries and other forms of unprotected exposure to blood and body fluids, the regular conduct of training, availability of infographic materials on the related concerns, and allocation of resources for healthcare worker safety programs. But the question is, what if we got pricked with needle? What will be the first aid, and how are we going to report it? The initial management right after the needle stick and sharp injury and other forms of unprotected exposure is to wash the affected area or the punctured wound with antimicrobial soap and water. If soap and water is not available, then use 70% alcohol. Then cover and press the wound or the affected area with clean gauze or cloth to prevent bleeding. Then report the incident to the immediate supervisor or head nurse on duty before visiting the infection prevention and control unit. Then the next question is, what will be the steps in reporting when inside the infection prevention and control unit? So at the start of reporting, or when a healthcare worker reported the incident to infection prevention and control nurse, the IPC nurse will provide the healthcare worker with necessary report form. The title of the name of the report form rather is report form on needle stick and sharp injury and other unprotected exposures to blood and body fluid, and the IPC nurse will assist him or her in answering the question being asked by the form. If the incident happened during weekends, you may contact the IPC nurse by sending message or through phone call for proper instruction. Then the next step is for the healthcare worker to undergo further interview and counseling regarding bloodborne infections, vaccination, and other infection prevention and control protocols. The IPC nurse interviews the client with regards to when and how the needle stick injury and blood and body fluid exposure happened in order to obtain the specific details of the event and validate his or her answers on the report form, and determines the client's vaccination history, specifically hepatitis B. If the patient where the contaminated needle was used or where the healthcare worker had unprotected exposure to blood and body fluids was known and identified, the IPC nurse interviews the worker as to the diagnosis of the client and risks for or presence of bloodborne diseases. Also, the IPC nurse gives advice to healthcare workers to coordinate with the attending physician of the patient regarding the possibility of determining the status of the patient as to hepatitis B, C, and HIV, if unknown and with risks. The IPC nurse also assesses the client's knowledge or the healthcare worker's knowledge on bloodborne diseases and infection control and provides relevant information and such. If the healthcare worker who got pricked with needle or who had unprotected exposure to blood and body fluids got exposed to suspected and confirmed HIV case, the employee or the trainee will be referred to HIV/AIDS core team office near the infection prevention and control unit or adjacent to infection prevention and control unit for further evaluation and screening. The third step or major step in reporting a needle stick and sharp injury and other unprotected exposure is for the healthcare worker to undertake screening through review of his previous laboratory results or taking recent tests. The IPC nurse, based from the data collected in the form or based from the data collected during the interview, will determine if what are the laboratory tests that a healthcare worker who had needle stick injury. The third major step in reporting needle stick and sharp injury is for the healthcare worker to undertake screening through review of his laboratory results or taking recent tests. The IPC nurse conducts screening by reviewing his recent laboratory results if available. So if the result or if there is available laboratory result less than 6 months from the time of the incident, then we can consider these laboratory tests as our baseline. Then, we will assist now the clients in taking new tests, be it hepatitis B surface antigen or HBsAg, hepatitis B surface antibody or anti-HBs, HCV antibody test, and HIV antibody test. If referred to HAC office, the healthcare worker will be assisted by the HAC nurse for pre-test counseling and testing for HIV antibody. Then the fourth step in reporting needle stick and sharp injury is when the healthcare worker, after performing all the laboratory tests and after having the laboratory test result, the healthcare worker shall present the laboratory result to infection prevention and control nurse. At the Infection Prevention and Control Unit, the result will be relayed to the IPC unit physician, and it is the IPC unit physician or the nurse who will conduct counseling regarding the result of the laboratory test and the possible management at the occupational clinic. All healthcare workers or all BMC healthcare workers who had a needle stick and sharp injury, regardless of the result, will be referred to occupational health clinic for further evaluation and management. And if needed, will be referred to other clinics. Referral to occupational health clinic is needed, particularly if the nurse, the doctor, or other healthcare worker needs post-exposure prophylaxis for wound, or if the patient, or if the healthcare worker rather, needs to receive hepatitis B titer. And the last step is that the Infection Prevention and Control Unit will coordinate to the immediate supervisor of the healthcare worker who got pricked with needle or a healthcare worker who had unprotected exposures to blood and bloodborne pathogens to issue requests for action. So the purpose of request for action here is to strengthen the implementation of infection prevention and control practices to prevent the possibility of having another needle stick injury or unprotected exposures. Due to these occupational health risks, healthcare workers, before practicing in the acute care hospitals or in other healthcare settings, must be vaccinated at least to hepatitis B and COVID-19. Vaccination per se is considered as the most effective way of protecting healthcare employees from getting infected with highly infectious diseases within the workplace. With this, the following protocols and vaccination have been established here in our institution. All healthcare workers shall be vaccinated against hepatitis B, either primary, series, or booster doses, and shall be facilitated by the employee's clinic specifically during pre-employment screening, annual medical evaluation, and after needle stick injury or unprotected exposure to blood and body fluids. Continuous vaccination of booster doses against SARS-CoV-2 is highly encouraged also in response to COVID-19 pandemic. Other vaccines aside from hepatitis B and SARS-CoV-2 that are highly recommended for healthcare workers are BCG, diphtheria, influenza, measles, meningococcal, pertussis, polio, rubella, and varicella. Other vaccines may be introduced to healthcare workers depending on the institutional needs or if with existing international and national guidelines. In case that available vaccines are limited, the employee's clinic in coordination with Infection Prevention and Control Unit shall identify the personnel who highly need the vaccine protection. The decision depends on the vulnerability of the personnel and the clinical area where they are assigned to the disease which the vaccine is after for. The employee's clinic shall have vaccination records of all the BMC employees. Another activity under standard precaution is the reprocessing of the medical items or devices. So in every healthcare facility, we classify the medical items according to the Spalding classification. So based from the Spalding classification, that there are three groups of medical items: the critical, the semi-critical, and the non-critical. For the critical items, these are the medical devices used in invasive surgical procedures. The level of reprocessing required is sterilization. In this institution, the main sterilization method or the primary sterilization method is through the use of autoclave. For the semi-critical items such as the respiratory devices, be it laryngoscope blade, reusable bag valve mask, and invasive ultrasound probe, wherein these materials have contact with intact non-sterile mucosa or non-intact skin, the preferred level of reprocessing is through the use of high-level disinfectant. And last group of medical items are the non-critical items such as digital thermometer, ECG leads, pulse oximeter, non-invasive ultrasound probes that are being used in contact with intact skin. And the level of reprocessing required is through the use of cleaning or low-level disinfection. In this institution, the primary solution being used in cleaning is through the use of bleach solution. Either 1:100 or 1:10. Then after the cleaning, these items must be stored in a designated cabinet. One of the major aspects under standard precaution that we need to consider in creating a safe and medical center is the cleaning and disinfection of the environmental surfaces. In our hospital, these are the common microorganisms that are prevalent in the different clinical areas. And in order to prevent that, we need to implement effective environmental cleaning and disinfection. That's why in our institution, in our facility, we use bleach solution as a primary material or primary solution in cleaning and disinfection of the environmental surfaces. The preparation could be 1:100 if we're going to clean and disinfect surfaces such as tables, chairs, and other possible contaminated surfaces except for the floor. But if we're going to clean the floor, we need to use 1:10 solution. But the question is, how are we going to make the 1:10 solution and 1:100 solution? So even if we are not the responsible person to clean and disinfect the environmental surfaces, at least we know how to do the 1:10 and 1:100 solution. So the process on making 1:10 and 1:100 solution is reflected on the screen. Of course, part on ensuring proper environmental cleaning and disinfection is to make sure that the principles of proper hospital cleaning are observed during the cleaning procedure. Number one principle is that we need to clean from cleanliest to dirtiest, from dry to wet, from top to bottom, from those minimal hand contact to those with commonly touched surfaces. And of course, that there must be a proper frequency in performing disinfection. For the high touch surfaces, it must be done every shift or as needed. For the low touch surfaces, it must be cleaned when visibly soiled and on periodic basis. and for the busy areas once a day or when visible soiling is observed. But what if the standard precaution is not enough to protect the healthcare workers, particularly if we are managing highly infectious patients? That's when the transmission-based precautions will be implemented. But remember, in implementing transmission-based precautions, such as contact, droplet, and airborne precautions, it is being implemented on top of the standard precautions. Meaning to say, both the standard and the transmission-based precautions shall be implemented when managing patients that are suspected, or whether it is a probable or a confirmed case of highly communicable or infectious diseases. So in order to understand transmission-based precaution, let us have a deeper understanding on what are the contact, or what is contact rather, what is droplet, and what is airborne precaution. When we speak of contact precaution, this pertains to the set of practices that are being observed when managing patients with contact transmissible diseases such as scabies, infectious gastrointestinal diseases, Ebola virus diseases, or patients with multi-drug resistant organisms. And what are the set of precautions under contact precautions? First, we need to isolate the patient immediately in a single room. If the number of patients under contact precautions exceeds the number of isolation rooms, the following principle shall be applied. Patients with conditions that may facilitate transmission shall be prioritized for a single patient room. Patients who are infected with the same pathogen shall be placed in one room. The distance between each bed should be 1 meter or more. However, if the patient who require contact precautions need to be placed in a room with a patient who does not have the same infection due to shortage of isolation rooms, the following principle shall be applied. Patients on contact precaution shall not be placed in the same room with patients who have conditions that may increase the risk of adverse outcome from infection or may facilitate transmission, such as those patients with immunocompromised condition have anticipated prolonged length of stay. Each bed must have a spatial separation of at least 1 meter with the other bed. Plastic barriers or curtains could be, if possible, to completely separate each bed and minimize the possibility of close contact. Change gloves or other personal equipment and perform hand hygiene between contact with patients in the same room, regardless whether one patient or both patients are on contact precautions. Wear the needed personal protective equipment as discussed. Limit the movement or transfer of the patients to essential medical purposes only. Ensure that the infected or decolonized areas of the patient's body are covered or contained. Use of disposable or dedicated patient care equipment. However, if common use of equipment for multiple patients cannot be avoided, cleaning and disinfection of the equipment before and after using it to another patient shall be observed. Cleaning and disinfection of the isolation room, specifically on the frequently touched surfaces of the patients, watchers, and healthcare workers, shall be done daily or as needed by the housekeeping staff. The second type of transmission-based precaution is the droplet precaution. So, droplet precautions are a set of precautions or set of procedures that are being applied when managing patients who are suspected, probable, or confirmed of having droplet transmissible diseases, such as diphtheria, pertussis, avian influenza, meningococcal diseases, SARS, COVID, and other illnesses. The set of precautions for suspected, probable, and confirmed patients of droplet transmissible diseases are the following. If the health condition can tolerate, the patient shall wear a mask at all times. The patient shall be immediately placed in a single room. If the number of patients under droplet precautions exceeds the number of isolation rooms, the following principle shall be applied. Patients who have respiratory symptoms such as excessive cough and sputum production shall be prioritized for a single patient room placement. However, patients who are infected with the same pathogen shall be placed in one room for cohorting, provided the distance of each bed should be 1 meter or more. If the patient who require droplet precautions need to be placed in a room with a patient who doesn't have the same infection due to shortage of isolation rooms, the following principle shall be applied. Patients on droplet precaution shall not be placed in the room with patients who have conditions that may increase the risk of adverse outcome from infection or may facilitate the transmission, particularly those who are or those patients who have immunocompromised state. Each bed must have spatial distance of at least 1 meter with the other bed. Plastic barriers or curtains would be, if possible, to completely separate bed and minimize the possibility of close contact. Change gloves and perform hand hygiene between contact with patients in the same room, regardless of whether one patient or both patients are on droplet precautions. Wear the needed personal protective equipment, specifically masks, at all times. Limit the movement or transfer of the patients to essential medical procedures only. Ensure the patient wear medical masks when outside the room. Cleaning and disinfection of the rooms by the housekeeping staff shall be done every shift or as needed. The last type of precaution under transmission-based precaution is the airborne. The airborne precautions can be applied to all suspected, probable, and confirmed patients of infectious diseases. At present, there are only 3 diseases that can be transmissible through airborne route, and these are measles, chickenpox, and tuberculosis, pulmonary tuberculosis. This can also be applied to all patients with droplet transmissible infections if these patients will undergo aerosol generating procedures. But what is the set of precautions that we need to implement for suspected, probable, or confirmed patients of infectious diseases transmissible through airborne? Number 1. The patient with airborne diseases shall be placed immediately in an isolation room, preferably an airborne infection isolation room. In the event of an outbreak or exposure involving large number of patients who require airborne precautions, cohort patients who are presumed to have same infection based on clinical manifestations and diagnoses in areas of the facility that are away from other patients, especially patients who are highly susceptible for infection. Convert regular rooms as isolation rooms, use of exhaust fans or portable HEPA filters, and manipulation of windows and doors shall be advised. Wear the set of personal protective equipment recommended in managing and transporting patients under airborne precaution. The Infection Prevention and Control Unit recommends the use of N95 masks when managing patients with infectious diseases transmissible through airborne route, rather than using a simple face mask. Limit the movement or transfer of patient to essential medical procedures only. Ensure that the patients wear medical masks when outside their rooms. For patients with skin lesions associated with varicella or smallpox or draining skin lesions caused by Mycobacterium tuberculosis, cover the affected areas to prevent aerosolization or contact with the infectious agent in skin lesions. And of course, use of dedicated patient care equipment is highly encouraged. However, if common use of equipment for multiple patients cannot be avoided, cleaning and disinfection of the equipment before and after using it to another patient shall be observed. Cleaning and disinfection of the isolation room must be done every shift or as needed. And in order to ensure that there will be a proper adherence of healthcare staff to the transmission-based precautions, the Infection Prevention and Control Unit implemented coding strategies in reiterating transmission-based, standard, and vector-borne precautions for patients with infectious diseases and healthcare-associated infection. Color coding strategy, such as reflected on the screen for the contact precaution, the coding is CP; for the droplet precaution, DP; for the airborne precaution, AP; for the vector precaution, VP; and for the standard precaution, applicable to those patients with hepatitis B, C, HIV/AIDS, Ebola virus disease, and other emerging infectious diseases, the code is SP. So, the codes, depending on the precautions based on the infectious illnesses, shall be attached in front of the patient's chart to serve as a visual reminder for the healthcare staff. Again, the code will be attached on the chart depending on the doctor's order. If the patient has infectious disease or healthcare-associated infection, where two or more precautions need to be observed, the corresponding codes shall all be placed in front of the patient's chart. The infographic and the coding of the transmission-based and transstandard precautions shall be distributed and posted in the nurse's station of every clinical and specialized unit. The Infection Prevention and Control Unit shall monitor the compliance of each clinical area in terms of the color coding strategy at least every quarter or twice a year. So from the standard and the transmission-based precaution, let us move now to the third and the last subtopic, which is the steps on consultation, screening, isolation or quarantine, and resumption to duty of those healthcare workers exposed to highly infectious patients or to those healthcare workers who have signs and symptoms of highly communicable illnesses. Healthcare workers who have been exposed to patients or colleagues with highly communicable diseases shall adhere to the following protocols. Monitor daily the health conditions for the development of signs and symptoms. Consult immediately to employees' clinic for assessment and post-exposure prophylaxis. Referral to other clinics, ABTC, or the animal bite clinic for exposure to rabbit patient shall be made if needed. Then wear the needed personal protective equipment while on duty. If signs and symptoms develop after exposure to locally endemic infectious diseases, the healthcare worker shall inform his or her immediate supervisor, consult a physician, preferably at OPD, undertake confirmatory and other related tests, and undergo home quarantine while waiting for confirmatory tests or home isolation if confirmed to have communicable diseases. Hospital confinement is the best option for severe and critical cases. If signs and symptoms develop after exposure to emerging and re-emerging infectious diseases such as COVID-19, monkeypox, Ebola virus disease, and other, the healthcare worker shall inform his or her immediate supervisor and shall consult a physician assigned not at the OPD employees clinic but at the ERID OPD unit for assessment. He or she must undertake also confirmatory and other related tests and undergo home quarantine while waiting for confirmatory tests or home isolation if confirmed to have communicable diseases. The duration of isolation depends on the communicable disease that the healthcare worker has and as per advice by the physician. The table reflected on your screen shows the common duration of isolation per diseases. Resumption to duty. Healthcare workers who will resume to work after home or facility isolation due to communicable illnesses shall observe the following protocols. The healthcare worker shall undergo health reassessment at OPD employees clinic a day after the completion of the quarantine or isolation. So this is applicable only for those locally endemic communicable diseases. If the employees underwent consultation in a private clinic, a medical certificate issued by the said clinic and then notarized by lawyer shall be presented to the OPD employee's clinic physician. A healthcare worker shall be cleared by the physician after the thorough evaluation before the issuance of medical certificate, which is needed for the filing of quarantine and or sick leave at the Human Resource Management section. If not medically cleared, the healthcare worker shall follow the advice of the physician, either extending his or her quarantine or sick leave or being referred to other clinics for further evaluation and management before being allowed to return back at work. For personnel infected with or exposed to emerging and re-emerging infectious diseases such as COVID-19, monkeypox, and Ebola virus disease, the following protocols shall be adhered prior to work resumption. Medical evaluation a day after the completion of the isolation or quarantine shall be done by the infectious disease specialist or resident on duty in a designated clinic for IRID cases only, which is the IRID outpatient unit. Once cleared, a quarantine certificate and confirmatory test shall be issued by Hospital Epidemiology and Surveillance Unit. Also, for healthcare workers infected by IRID, medical certificate by the infectious disease specialist shall be provided before proceeding to employee's clinic for final assessment. Another medical certificate from record section shall be issued after the final evaluation at the employee's clinic. Work resumption shall be accomplished if needed a day before going back to work. Documents issued during reassessment, such as medical certificate, quarantine certificate, and confirmatory test result, shall be presented to the Human Resource Management section for the filing of quarantine and or sick leave. And that ends my discussion on the hospital infection prevention and control practices. If you have concerns or queries regarding infection prevention and control practices, you may visit Infection Prevention and Control Unit located at the old building adjacent to the HIV/AIDS core team office. Here are my references. And before I end the presentation, allow me to leave you with this statement from Christopher Howson. Care is an absolute, prevention is the ideal. Thank you.
Good day everyone, I'm Engineer Ruben Espartines, Chemist 2 here at BMC and a Pollution Control Officer. I'm here to talk about solid waste management here in Bicol Medical Center. Okay, when it comes to waste management, we have to follow rules about waste management because there are legal basis for all of this. First of all, there is Republic Act or RA 6969, also known as the Toxic Substances and Hazardous and Nuclear Waste Control Act of 1990. Next to that is RA 8749, which is the Philippine Clean Air Act of 1999. After the Toxic Substances and Air, we have RA 9003, which is the Ecological Solid Waste Management Act of 2000. So the next would be, after the air, after solid, we now come to Republic Act 9275, which is the Clean Water Act of 2004. So having covered all the solid, liquid, and gas phase of our wastes, we now come to RA 11058, which is strengthening compliances to occupational safety and health standards, of which all of us are covered, being workers here at BMC. Also, there are other environmental laws and their implementing rules and regulations. I will not cover this anymore as there are a lot of them. There are also other labor laws. Since we are all workers, government workers, and servants, I will not cover these anymore. Now, internally, we have different administrative orders from the different departments of the government. So they can be either solo or jointly, coming from DNR, the DOH, the Labor and Employment, and the ALG, and other departments also. Also, there are other local ordinances which we have to follow, whether they be provincial, city, municipal, and even barangay ordinances when it comes to waste management. And for us here at BMC, we do have policies, regulations, and guidelines when it comes to waste management. Sample of this would be Hospital Memorandum or Memorandum Number 026, Series of 2022, which is last year, where we will be implementing prohibition on the unnecessary use of single-use plastics here at BMC. So you can see from the memorandum order, the following are not allowed: your plastic cups, your drinking straws, plastic coffee stirrers, tin-filmed sandbags, and plastic spoons and forks. Now, also a basis for having waste management is we know that for us a healthcare facility, we generate or we produce 4 basic types of solid wastes. What are these? They are either infectious or hazardous waste. They can be biodegradable, they can be recyclable, and if we cannot categorize the waste into any of these 3 first categories, they become residual waste, and usually these are non-biodegradable. So what are examples of infectious and hazardous waste that we produce at PMC? These are basically the gloves, the masks, disposable diapers, sanitary napkins, the urine bags, anything that we use for our patients and what the patients use. Also included here as hazardous waste would include fluorescent lamps that are busted, used batteries, even used oil from cars or used oil from the kitchen. So for this infectious and hazardous waste, we put them into yellow bags or yellow colored bins. We have stickers to indicate which bins to use and what would be placed in these bins. For our biodegradable waste, examples of these are fruit peelings, vegetable peelings, leftover food, and wet paper or cartons. So these we place in green bags and green containers, and we have stickers to indicate these places. For recyclable waste, this can include our IV fluid containers, which are made of thick plastic or glass, bottled water containers, which there are a lot of, juice containers, even soft drinks can. So for the residual waste, that which we cannot categorize in the first 3 types of waste, these include our Tetra Paks, candy wrappers, usually the sachets that we use. Okay, these are placed in black bags. So stickers, posters, and bags and bins are colored black. When it comes to waste management, we can categorize or group the different stages of waste management. So there are basically 3 large groups when it comes to waste management. These are the entry or ang pagpasok ng mga basura, the generation or pagproduce ng basura sa mga bagay na pumapasok, and finally, disposal or pagtapon ng mga basura. So what comes inside our institution, BMC? Basically, man and materials. So man, they can be either the patient or the bantay, the visitors, and tayo, mga staff. And there are also the entry of the different materials we use here at BMC. And as stated earlier, as much as possible, we want to ban the unnecessary use or the use of plastics, single-use plastics. Okay. After entry of these materials and using the things that we need, definitely there will become waste generated or pagkakaroon ng mga basura. So, Republic Act 9003 explicitly states that we have to segregate at source the waste that we generate. So the very essence of RA 9003 is segregation at source. Paghiwa-hiwalay ng mga basura doon mismo sa lugar kung saan na-generate or nagkaroon ng basura. And we have a policy also of no segregation, no collection. So as much as possible, we want to segregate so that all our wastes, lahat ng basura natin, madadala. And finally, we come to the disposal of our waste. So, paano natin tinatapon ang basura natin? Unang-una, first of all, this would be internal or pangloob lang na pag-handle o pag-dispose ng waste. Pwede nating i-compose yung mga biodegradable waste natin. Pwede nating ma-recycle or reuse or repurpose ang waste natin tulad ng mga containers ng Zonrox. We can use them as puncture-proof containers for our sharps. Then we also do treatment of our waste. And finally, we bury our waste that are biodegradable. And the other way of disposal would be external o panglabas na paraan ng pagtatapon ng basura. Nilalabas natin ang ating mga basura. So first of all, we are fortunate enough to have a good relationship with our City Solid Waste Management Office because they are the ones who take out our residual waste, and we also give them the recyclable waste. The city will be in charge of disposing our recyclable waste. And the other way of disposing our waste externally would be we have to get a contractor for the transport, treatment, and disposal of our waste. Usually, these contractors handle our infectious and our hazardous waste. As of today, ongoing, actually, the whole year round, ongoing ang disposal, ang transport, treatment, and disposal of our waste. And showing you, through the years that actually I've been here at BMC, these are the facts that I have gathered. So in 2015, first transporting cost for BMC amounted to something like 2 million pesos. And year on year, it has been increasing. Basically, you could see that we have an increasing number of patients here at BMC. And for this year, 2023, our contract for transport, treatment, and disposal of our waste amounts to 9 million pesos. And from our experience, this can still go up because of the increasing number of patients here at BMC. There are also an increasing amount of waste. So in order for us to lessen the cost of transportation, we have to know that the amount of the contract would be based on the weight of the waste that we gather and they take from us. Meaning, if we produce less waste, that means less cost for all of us. Thank you very much.